Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is acne, which falls under the dermatology section. So what is acne? This is a multifactorial disease of the pilosebaceous unit due to increased sebum production, leading to increased keratinization and blockage of follicles. This results in overgrowth of Propionibacterium acnes. Acne is extremely common. It affects all ages, but the peak age is in late teenagehood. Signs and symptoms primarily encompass blackheads and whiteheads, which cover the face, back, and upper chest. Blackheads are open comedones, whereas whiteheads are closed comedones. Inflamed papules and pustules can be of varying severity. Scarring and hyperpigmentation may result due to hyperinflammation, particularly in darker skin types. History is key, with particular attention required to the medications, as these can cause drug-induced acne, as we will find out on a later slide. Diagnosis is clinical. Sudden severe onset or unusual resistance to treatment should prompt investigations for secondary endocrine problems, such as hyperandrogenism. Drug-induced acne can be due to any of the following drugs, and they include steroids, and this includes the oral, inhaled or anabolic types, phenytoin, lithium, isoniazid, quinine, iodides, and disulfiram. There are several endocrine causes of acne, including polycystic ovary syndrome, Cushing's syndrome, congenital adrenal hyperplasia, and adrenal androgen-secreting tumours. The treatment really depends on severity, so we can classify acne as mild, moderate, or severe. In mild cases, topical treatments including benzyl peroxide, salicylic acid, and retinoid, plus minus topical antibiotics may be useful. In moderate cases, oral antibiotics such as doxycycline or cyproterone acetate in females, again plus or minus topical therapies may be useful. In severe cases, oral isotretinoin is required, and this requires a secondary dermatology opinion. In 90% of cases, acne is cleared by the age of 25. However, severe acne can lead to long-term scarring as well as psychological sequelae. Now let's do some questions. A 20-year-old female presents with an acneiform rash over her face, which has not responded to topical treatment with retinoids or benzyl peroxide. She has noted irregular periods over recent months and has gained 2 stones in weight. She has also noticed excess growth of facial hair. Which of the following is most likely to be the underlying cause of her acne? So our options are polycystic ovarian syndrome or PCOS, Cushing's syndrome, congenital adrenal hyperplasia, adrenal androgen secreting tumour, or phenytoin use. Now, all of these can be secondary causes of acne, but it's important to look at the scenario as a whole, including the patient's gender, age, and the other symptoms that she's experiencing, as well as the time frame. And really, the most appropriate answer in this case is PCOS, which is the first answer. Question 2. A 25-year-old female with long-standing severe acne presents to her dermatologist for consideration of isotretinoin therapy. Which of the following statements is incorrect about medication counselling for this drug? She will need to be supported on a pregnancy prevention program whilst on the drug. She cannot breastfeed whilst on the drug. Effective contraception must continue at least 1 month after stopping the drug. Isotretinoin is contraindicated in hyperlipidemia. No dose adjustment is needed in cases of renal impairment. So pregnancy counselling and the presence of hyperlipidemia are 2 of the most important factors to consider when starting isotretinoin on a patient. And so the first 3 statements here are all true. Contraception should be used when taking isotretinoin, and it is not compatible with breastfeeding. Isotretinoin is also contraindicated in hyperlipidemia, and therefore the correct answer is that no dose adjustment is needed in cases of renal impairment. This is false, as you do need to adjust the dose if there is renal impairment. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.